we have a being intensivist, we have very limited exposure to this, mostly because these are niche areas happening in very few limited hospitals. But luckily, I am working in a cancer hospital and I am involved with post-transplant patients management. So we like to have them in the ward of the transplant area rather than bring them to the ICU. So there are times they come to ICU, and even to prevent the shifting of patients to ICU, a lot of time we provide our critical care and acute care service to the post-transplant area also. We move to the bone marrow transplant unit, try to optimize their therapy and try to prevent them from getting more critical and shifted to ICU. So what I'll do in the next 15-20 minutes, we'll talk about use of prophylaxis, empirical therapy and definitive therapy. So a few words about hematopoietic stem cell transplant. It involves administration of healthy hematopoietic stem cell in patients with a dysfunctional or depleted bone marrow. And it helps to augment bone marrow function in coming days. Depending on the disease that we are treating, before hematopoietic stem cell transplant, we have to destroy the tumor cells and generate functional cells that can replace these dysfunctional cells. This can sometimes be taken for the patient, sometimes for patient's family, sometimes for unrelated patient, unrelated person, depending on the genetic mismatch, which is called matched unrelated donor, which is not directly related to patients. But though it sounds very simple, it's a very complicated situation because we are playing with patient's immune system, which is a generalized thing and involving all part of the patient's body. So a lot of different kinds of complications that can develop, like graft versus host disease. This patient needs significant immunosuppression to prevent these new cells to be destroyed by the underlying immune response. Because of immunosuppression, they can develop infection. There is a lot of toxicity related to conditioning regimen like immunosuppression, sometimes veno-occlusive disease, and they can develop organ failure, and the worst situation is the graft rejection. It can happen immediately within the next few days, acute graft rejection, and it can happen after few days, which is called a chronic or delayed graft rejection. So if we again look at the complications related to the fungal infection is one of the common challenges in hematopoietic stem cell patients, and the most common funguses are Candida species and Aspergillus. There are other molds, non-Aspergillus molds, that also can cause infection like Zygomycetes, Fusarium and Cephalosporin. So to decide on empirical therapy, we need to know that which is our antibiotic, what are the fungus that is common in our unit, and accordingly we need to decide about it. Most of the units has a problem with the Candida. Yeast that spreads systematically from the mucosal surface. Post-transplant patient develop extensive mucositis, and there can be transplantation of fungus from the blood. And after entry to the blood, they can have candidiasis, that is presence in the blood, or they can deposit in different vital organs leading to invasive candidiasis. Aspergillus, so basically environmental mold and ubiquitously present. So just identifying an Aspergillus from respiratory sample is not enough. We should have to be symptomatic. And just because of that, optimal HEPA filter availability or optimal HEPA filter functioning into the transplant is very, very important. If there is a breach, a patient may develop invasive aspergillosis and complication. Though these patients mostly receive an antifungal prophylaxis, anti-mold prophylaxis, and the standard of treatment presently is a posaconazole as a prophylaxis. Now, if you look at the risk of fungal infection, usually the peri-transplant period divided into 3 periods. Pre-engraftment, that is, the patient has literally 0 WBC cells, and 2 to 3 weeks, depending on the type of transplant, they will take time. So these are basically a neutropenic situation for pre-engraftment, early post-engraftment and late post-engraftment. Early engraftment goes up to 100 days. There is a different kind of infection patient can develop in this period, and late post-engraftment. Early post-engraftment is mostly more common for viral infections like CMV, HSV, and they receive prophylaxis, PCP, so they receive prophylaxis. So we look at the risk factors for post-transplant patients. So there are some common risk factors that will be present in both sides, like age and patients with immunosuppressed state, neutropenia. For type of transplant is important because autologous transplant has the least risk. Allogenic or one transplant with a less matching will have more risk because they will need a much intense immunosuppression in this situation. Acute and chronic GVHD is as bad like a transplant. They can develop severe immunosuppression Because of extensive gut GvHD, there will be extensive mucosal loss and cause transplantation of fungus, basically Candida. Patient may have an underlying other comorbidities that can make them prone to infection, presence of cytomegalovirus disease, high dose of steroid and intensiveness of the conditioning regimen. So depending on that, along with associated with prolonged neutropenia and delayed immune reconstitution, increased risk of fungal infection will be noted. So why maintain delayed immune reconstitution? It will depend on the type of immunosuppression, the type of the transplant we are dealing with. So if your time will lay, an autologous transplant, probably the WC cells will come back by 7 to 10 days. If it's an allogenic transplant, depending on the intensity of the conditioning regimen, or what transplant, it may take 2 to 3 weeks for the WC to come back. We know, rather than the intensity of the neutropenia, it is the prolonged neutropenia that makes patients more prone for fungal infection. So there are some risk factors for Candida and mold. For Candida, it is mostly the age, underlying disease, aplastic anemia, transplant, gut involvement. Mostly they transplanted from the gut or they transplanted from the lungs. So these are the two sites of infection. Entry sites for Candida. For invasive molds, they mostly start with a lung, that is the port of entry. After that, depending, because these are invasive molds, aspergillus, they can involve the vessels. In certain situations, they can cause disseminated fungal infection also. Like you can get aspergillus or a mucor, which involves the vital organs like lung, disseminated one, brain, kidney and all those things. So those can cause a big problem. So as I mentioned, in the pre-engraftment period, there is usually neutropenia and mucosal damage, most make them very prone for developing Candida infection. Post-engraftment is up to 100 days. You can see starts from 40. That means there are patients when the engraftment will take 35 to 40 days also. These are very unfortunate situations and patients have very strongly to see this situation because of infection. In the post-engraftment period, there is mostly concern related to GvHD because of T-cell abnormality, T-cell immune deficiency. And beyond that, there can be chronic GvHD, chronic immune restoration or secondary neutropenia because of inadequate bone marrow. And this is the time schedule that has been given for fungal infection. The grey one is for the Candida and the orange one is the mold. Why the incidence of Candida is less in the first part? Mostly because, not because they are not susceptible, mostly because they are all already on a prophylaxis. In all kinds of transplant, even in allogenic, they receive anti-Candida prophylaxis. This is allogenic transplant. Autologous, they receive Candida prophylaxis. For allogenic, they receive mold prophylaxis also. So eventually, this patient has a lesser risk of Candida infection because of the prophylaxis, not because patient is not at risk. Even then, as I discussed already, patient has a higher risk of incident infection with allogenic transplant and less with autologous transplant. So there is very limited data regarding the antifungal prophylaxis and the big fungal infection in transplant patients. There are two articles we have marked here, one from Cancer Hospital, one is from Medanta and from the Rajiv Gandhi Cancer Institute. In Medanta also this data is related to cancer patients. As I mentioned, Candida is the most common, followed by aspergillus. When you talk about the transplant patients, impact is significant because options of antifungal treatment is very limited. Higher antifungals are very toxic and they can develop significant complications and it's costly. Even after appropriate therapy, the morbidity and mortality is very high. So the main focus is on early detection, prevention. To be honest, first is prevention, that will give prophylaxis. Early detection is vector infection and appropriate treatment which is safer drugs. Know that when you talk about antifungal and safety, echinocandins always take the front seat. They are probably the most safe drug that is available at this moment. So, if you look at the option for antifungal treatment, it can be prophylaxis, that is when the fungal infection is not there, you try to prevent it in the high-risk patients. It can be empiric when the patient develops clinical symptom of fungal infection and you start antifungal empirically. It can be preemptive, that is your empirical therapy is supported by different non-culture based tests. Non-culture based test means it can be a PCR based test or it can be a beta-glucan, galactomannan, that is biomarker based test. But the culture is not there. And pathogen specific means you have already identified the fungus from the appropriate site and you are going for a targeted therapy. As I already discussed, options are azole, echinocandin and polyene. Polyene, this is the broadest spectrum of antifungal, but if you want to give them for a very longer duration, the challenge is regarding the toxicity. So in that regard, it is very difficult to continue with with an amphotericin B for 40 days or 50 days or 60 days or 100 days. So we try to choose more safer options. Still, the prophylaxis of choice is posaconazole in case of post-transplant situations. But you need to remember there are a lot of drug-drug interaction that can happen with as well when you are using them in a post-transplant situation. So sometimes you may have to change to echinocandin. Now, echinocandins, as I just mentioned, these are a semi-synthetic cyclic lipopeptide. The non-competitive inhibitors of 1,3-beta-glucan synthase and inhibit the cell wall synthesis, prevent cell wall synthesis and contribute to a better outcome. It's a very specific for the fungus because this molecule is not present in the human body. As a result, the complication of toxicity chances is very, very less. These are the three anti-echinocandins presently we have, that is mica, caspa and anidula. They have a significantly overlapping pharmacokinetic features with certain advantage of certain molecule. And they are only available as an IV, no oral formulation is available. So if you look at the overall pharmacokinetics of echinocandin, they have a linear kinetic or intravenous use. Cmax is similar between caspa and mica, which is higher compared to anidula. So usually in non-hematologic patients, routine patients, still our first choice is caspa because they have a higher Cmax. Steady state, if you look at the steady state of AUC, again caspa and mica is better than anidula, and it is a favorable drug-drug interaction which become very important in a peri-transplant situation. But problem with the caspa is that if there is a liver dysfunction, you need to decrease the dose. Safety profile is little dodgy, specifically if there is a child plug C. And these patients, a post-transplant patients, a peri-transplant situation can develop a VOD, that is veno-occlusive disease, which causes a progressive increase in bilirubin, probably from the second week. In that situation, continuing with the caspofungin can be difficult. And because of that, very few people has explored the caspa. Most of the data in the peri-transplant period, hematopoietic transplant period is related to micafungin. Because of the safety profile, less drug-drug interaction, and with the toxicity. So again, if you compare the three molecules, if you look at the Cmax, micafungin, Cmax and AUC, micafungin and caspofungin is much better compared to anidula. So that means the drug level can be much better achieved compared to the present options, other options like anidula. And the rest of the parameters is also comparable, but the drug hepatic derangement is a concern, specifically for caspofungin. So if you look at the spectrum of activity, it covers most of the candida that can happen, along with aspergillus to some extent, some of the aspergillus like fumigatus, flavus and terras. And we need to know what are the fungus it doesn't cover. Zygomycetes, that is mucor, or mucorrhinic group, Cryptococcus, Fusarium and Trichospora. So if the patient is on echinocandin, that is called micafungin, and there is a clinical failure, the patient develops a breakthrough fungal infection, this is the fungus we need to think of. That is Trichospora, Fusarium, Cryptococcus or a mucor. This is the data we are already suggesting that most of the time it is the micafungin among the echinocandin that has been explored in this area. We do not have enough data to comment about other two echinocandin. So even in my unit, gradually we are moving. Possibility of hepatic dysfunction with a hepatitis or hepatic failure, it is not applicable for echinocandin, micafungin or amsulafungin, it is only for caspofungin. In patients who experience abnormal liver function, again, caspo is a contraindication, mica should be the drug of choice. And mica can also have a hypersensitivity reaction, renal failure, those are very, very rare. And for pregnancy, we do not have data at this moment. So these are the common adverse events. Again, the gastrointestinal disorder or the liver disorder, transaminitis is minimum with mica compared to caspofungin and anidulafungin. So recommendations, we look at the recommendations. The strongest recommendation among the echinocandin, the strongest recommendation is for mica, followed by caspa, because the caspa has a very, very limited data in terms of its usage. Still, the first drug of choice is posaconazole, as I mentioned, as a prophylaxis, maybe voriconazole in certain situation, but when these drugs are not able to use it because of drug-drug interaction, liver dysfunction, the drug of choice for prophylaxis is micafungin. And you are suspecting a fungal infection, specifically if the patient is developing candidiasis, drug of choice will be micafungin. If the patient develops a aspergillus infection, on top of a voriconazole or an azole, then you have to probably change for an amphotericin along with the micafungin or caspofungin. Though in that situation, data for mica, for caspa as a breakthrough infection is little limited, But in this subgroup, probably that will be the drug of choice. I would like to conclude here. Thank you.
Thank you, sir. Thank you so much, sir.